From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing probably one of our most talked about articles of the year, Mortality Among Surgeons in the United States. We are here with two of the authors, Dr. Anupam Jena and Dr. Vishal Patel from Harvard Medical School and Brigham and Women's Hospital Department of Surgery, respectively. Thank you for joining us on what I know is a topic I think every surgeon cares about, our own mortality, and I think something that actually is becoming more and more obvious and more discussed, which is the idea that to provide the best care to our patients, we as surgeons also need to take care of ourselves. So to start, can you tell us really why you decided to look into this?
Sure. So I think there's two reasons. The first is that, as you just noted, being a surgeon is very different than most other occupations. So the level of stress, the amount of work, the training, and what the body takes on during that long process of training, I think are particularly unique. And so you might expect to see health effects of that kind of lifestyle and work. So that's the first reason. The second reason is that prior to this study, we'd actually done some other work looking at national data on physician mortality overall, not breaking it down to physicians and surgeons. And what we'd found there was interesting. We found that physicians in general, that is including surgeons, have lower mortality than the general population, which is not surprising. But there were certain groups of physicians which didn't fare as well. So, for example, women live longer than men in the general population, but that is not true among physicians and surgeons overall. When you look at that group of professionals, women don't do any better than men. So it's sort of an early signal that there might be some interesting things to find if you look at the health outcomes of surgeons.
For our listeners who may not have yet read the paper, let's dig into the paper itself and let's talk about the methodology. How did you discover the mortality rate of surgeons?
Right. So we used newly released data from the National Vital Statistics System, which focused on U.S. adults who died in 2023. Importantly, these death certificates now included a relatively new variable, which is the usual occupation. The usual occupation variable is reported by the decedent's next of kin, and the availability of this occupation field is what made the study possible. To calculate mortality rates, you need both the number of deaths and the size of the population at risk. So after identifying the surgeon decedents from the death certificate data, we matched those counts to population denominators from the American Community Survey. We then stratified both of these numerators and denominators by age, sex, and occupation. After that, we compared surgeons to several different groups: non-surgeon physicians, other highly educated professionals, which include lawyers, scientists, and engineers, and all other workers in the general population. Of note, we also age and sex adjusted all of our mortality rates to the U.S. standard population and calculated mortality rate ratios to quantify differences. And finally, we stratified the overall mortality rates by the leading causes of death for each group.
It's such a great methodology. And overall, let's talk about what you found. So your study included a review of over 1 million people who had died, 224 of which were surgeons, 2,740 were other types of physicians. And then you compared us to not only our non-surgical colleagues, but also similarly educated professionals and then the general population. So how did we compare?
So we found that surgeons do not share the mortality advantage seen among other physicians. Specifically, the mortality rate among surgeons was about 56% higher than non-surgeons, and that actually is roughly comparable to other highly educated professionals.
So non-surgical colleagues, my non-surgical colleagues, have a mortality benefit compared to similarly educated professionals and to the general public. And a little bit of that, I think, makes sense. But that mortality benefit is lost by people in my occupation, people being a surgeon. And so I really want to lean in on a couple things. So there's a big elephant in the room in that we as surgeons are dying at a higher rate than our non-surgical colleagues, and how we're dying is also different. Because I love how you then went into the causes of death. And so mortality from neoplasms was higher in surgeons than any other group, including the general population. Motor vehicle collisions were the fourth leading cause of death for surgeons as compared to the ninth leading cause of death in all other groups. Also, what I found interesting is that deaths from hypertension and assault, interestingly, were also ranked higher in surgeons than in any other groups. And that elephant in the room is why?
We don't love our surgeons enough. I think the short answer is that no. If you think about why it is that physicians do better than the general population, it's probably a few things. One is that they're more educated about medical issues, and so they can take better care of themselves that way. They might listen to medical recommendations that physicians make to them more. There's a general positive correlation between education overall and health outcomes, so that's going to be playing out more here. They have more access to medical care just by virtue of knowing other physicians, and they're wealthier. But for whatever reason, the aspects of being a surgeon seem to wipe all of that away. We don't talk about this so much in the paper, but there's a very robust literature on how workplace factors, overall stress seem to affect mortality, not just in correlational or associational ways, but actually in more causal ways as well. And so that's probably the leading hypothesis here, is that the stress of being a surgeon, some of it's determined by the nature of the work, other of it might not be, seems to have this effect on the mortality of surgeons.
And I will say my bias is my research in sleep deprivation and stress physiology in surgeons. And we know through our prior research that when a surgeon scrubs into a case, they get a cortisol spike. And whether a surgeon says they're stressed or not, and shockingly or not, surgeons aren't always the best at self-reporting their stress levels. But we know that we get these cortisol spikes that happen anytime we're scrubbing in. I'm a trauma surgeon. We know that in-house call leads to sleep deprivation as well. And so you're right. I think there is a very unique combination of physiologic factors that are associated with our jobs as surgeons that aren't necessarily always present in other specialties. And so do you think that any of this plays into, again, there's got to be something, right? Why are surgeons getting cancer at a higher rate? The motor vehicle collisions, interesting, hypertension and assault. Do you have any further thoughts or hypotheses about why this might be the case?
There's been a lot of literature, as you've noted, as to why motor vehicle collisions might be more common in surgeons. Even from my own personal experience, I'm a general surgery resident, and I have already, in my first few years, have had colleagues within my own class who have gotten into motor vehicle crashes after a long call shift. Now, the other findings, cancer especially, was one of the surprising sort of findings that we noted. And unfortunately, we just don't necessarily know why. There are several causes that people can speculate. For example, radiation is one of the big ones. So that also is dependent on your surgical specialty. Neurosurgeons might be more exposed to radiation than general surgeons. And that may also influence the type of cancer that you get. But because of the methods that we used, we only had a single year of data and a limited number of observations. And so stratifying by specialty or by cancer type was not really possible. This type of finding lends itself to hypothesis generation and future studies that might actually be able to investigate some of those interesting questions.
And Dr. Jena, what do you think is the future of this research? Now that we have these data, what should be our next steps?
I think two things. One is, Dr. Patel alluded to this, getting into the mechanisms of what might be going on. And one way to do that would be to try to understand what does the mortality look like across very specific specialties within surgery whose work requirements or habits or lifestyles might be different. I think that's one thing. Another thing that I'll tell you is we have done some other work, not in the field of medicine, but in the field of economics, where we've looked at birth outcomes of surgeons and physicians and lawyers in the state of Texas, where we had detailed data on the occupation of the mom. And we see two things. First is that birth outcomes of surgeon moms are worse than birth outcomes of lawyers and other educated people. And the second thing, which is interesting, and this goes to the mechanism, you may recall a couple of decades ago, there was a change in work hours for resident physicians. And what we see is that after those work hour reforms, or they call them duty hour reforms, there was improvement in birth outcomes of surgeon moms compared to prior to those reforms. And so that might indicate the fact that sleep presumably improved, total work hours presumably improved after those work hours reforms may have had a causal impact on the outcomes of surgeons' births. So I think that's sort of more mechanistic or causal evidence as to what might have been changing with respect to work hours and sleep deprivation. But I think, the picture is still probably unfolding.
Dr. Jena and Dr. Patel, thank you both so much for joining me to discuss your article about the mortality amongst surgeons in the United States. Our listeners can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.